So the patient is a newly diagnosed case of diabetes type 2. Firstly, we will advise lifestyle modification. And if the after this HbA1c is still 48, then we'll start the first hypoglycemic. If the patient is already on metformin, and his HbA1c is still high but less than 58, the threshold to add second anti-diabetic drug is on metformin, and his HbA1c is less than 58, such as in this case, HbA1c is 50. So we will not add a second anti-diabetic drug unless and until HbA1c level rise to 58 or more than 58. So when we advise lifestyle modification, a newly diagnosed patient with diabetes type 2 mellitus and already on metformin and has HbA1c is less than 58. So again, to add a second anti-diabetic drug, HbA1c must be 58 or more than 58. So we have a case of uncontrolled type 2 diabetes mellitus despite lifestyle changes, plus his EGFR is less than 30, plus he has a history of heart failure, plus his BMI is more than 30. So a person has uncontrolled type 2 diabetes mellitus despite lifestyle changes. His GFR less than 30, which two groups are contraindicated if the GFR is less than 30. Which two groups are contraindicated if the GFR is less than 30? Who will answer this one?
Metformin and sulfonylureas.
Yes, MS contraindicated in bad kidneys. With bad kidneys, MS, metformin, and sulfonylureas. So in this patient, we cannot give these two drugs. Now, patient also has a history of heart failure. So which two drugs are contraindicated in heart failure?
DP4
And
and glitens.
DDP4 are basically
Glitens are glitens, yes.
gliptins and glitazones.
Yeah,
Yes.
SGL.
No, SGLT2 are not contraindicated in heart failure.
It's not contraindicated.
SGLT2 has a protective effect on cardiovascular diseases.
Right.
So the two drugs or two groups that we cannot give in heart failure, and they have a G in them, such as gliptins and
Gliptins
glitazones.
Yes.
Gliptins and glitazones. Don't forget this.
Yeah.
And with BMI, high BMI, which drugs are contraindicated? So this patient cannot take MS, metformin, and sulfonylureas. This patient cannot be prescribed gliptins and glitazones. Now his BMI is also high. So with high BMI, which drug we need to avoid? Which anti-diabetic?
Sulfonylureas,
Hmm.
pioglitazone, and ripaglinide.
Repaglinide. That's right. SPR contraindicated in high BMI. So we cannot give him MS, metformin, sulfonylurea. We cannot give him gliptins and glitazones. We cannot give him repaglinide and So any of the anti-diabetic drug is not suitable for this patient. So we have to think of starting insulin. So DM type 2 in an obese patient with impaired renal failure, the only option that we have is insulin or gliptins, because gliptins such as DDP4 inhibitors, and they have no effect on weight, so they can be used in obese patients. And also they are not contraindicated in renal failure, so they can be used in this case. And if with gliptins the sugar levels are not controlled, then we'll think of starting insulin.
Oh, gliptins are contraindicated in heart failure. So why
Yes,
we are
they are.
giving
No, the scenario is that the patient is obese and impaired renal function.
Oh, okay, okay.
The other scenario was different.
Yes, yes, that's fine.
So remember that in bad kidneys, if the GFR is less than 30, we cannot give MS, metformin, and sulfonylureas. Another drug that you need to remember, if the patient GFR is less than 60, then we also avoid SGLT2 inhibitors. So in this scenario, a patient with uncontrolled diabetes and all these, GFR is less than 30, so all the drugs are contraindicated. Some are contraindicated due to this GFR, some are contraindicated due to heart failure, and some are contraindicated to BMI. So that's why the drug that we can give to this patient is insulin. Now, a patient with type 2 diabetes mellitus, microalbuminuria, and mild hypertension plus hypercholesterolemia. So, with medication we need to give to these patients? Anti-diabetic drug for type 2 diabetes mellitus, for microalbuminuria and mild hypertension. So, which is the drug of choice for the management of hypertension in diabetes? AC inhibitors. That's right. And for hypercholesterolemia, we'll prescribe atorvastatin. That's right. ACE inhibitor decrease GFR and decrease proteinuria. That's why they are renoprotective, and that's why they are the first line drugs to manage. So a patient with type 2 diabetes, BMI is more than 30. So which drugs need to be avoided in high BMI? SPR need to be avoided in high BMI, sulfonylurea, pioglitazone, and repaglinide. These three drugs are contraindicated.
glucophage is biguanide?
Yes,
Okay.
glucophage or metformin is biguanide. Maximum dose of metformin or biguanide is 200 milligram. So sometimes in Plab 1, they can ask you a question like this, that a person is on 500 is taking 500 milligram metformin and his HbA1c level is 53 or 54, still not in the target range. What is the next best step to do? Then you can select an option of increasing the dose of metformin. The maximum recommended dose of metformin and biguanide is 2000 milligram or 2 gram. The only diabetic drugs which can cause hypoglycemia. What are the anti-diabetic oral anti-diabetic drugs which can cause hypoglycemia?
Sulfonylurea and
Yes,
ribagina.
sulfonylurea such as gliclazide, glimepiride, and glibenclamide. So, if a patient, a diabetic patient, present to you and he is taking metformin and sulfonylurea and he has repeated attacks of hypoglycemia, then which drug you will stop? You will stop sulfonylureas. Similarly, in any scenario, if patient is on metformin and long-acting insulin and he has repeated hypoglycemic attack, then you will decrease the dose of insulin and not metformin because metformin does not cause hypoglycemia. So you will reduce or stop the drug that is causing the hypoglycemia, which can either be insulin or it can either be sulfonylureas. Now, this was all about the management of diabetes, type 2 diabetes mellitus. Now, some complication of diabetes mellitus. There are two types of complication of diabetes mellitus. One is acute complication and the second one is chronic complications. What are the important acute complications? Acute complication of diabetes mellitus include hypoglycemia, diabetic ketoacidosis, and hyperglycemic hyperosmotic coma or HONK. So acute complication of diabetes mellitus include hypoglycemia, DKA, and HONK. And chronic complication one are macrovascular, diabetic retinopathy, diabetic nephropathy, diabetic neuropathy, autonomic neuropathy, and somatic neuropathy. So all the neuropathies, retinopathy, and nephropathy, they are microvascular complication, and macrovascular include stroke, ischemic heart disease, and peripheral vascular disease. So we'll discuss one by one the acute complications. Complication of diabetes mellitus is hypoglycemia. So what can cause hypoglycemia in diabetic patients? In type 2 diabetics, the cause of hypoglycemia is sulfonylureas. So a patient on sulfonylureas present to you with features of hypoglycemia, then you will check his random blood glucose level. And the cause of hypoglycemia in type 1 diabetics is overdose of insulin. Hypoglycemia is alcoholism. The most common is alcoholism, and the second most common is diabetes, treated diabetes. So the most common cause of hypoglycemia is alcoholism. How alcoholism can cause hypoglycemia? Alcohol, remember that alcohol lead to glycogen depletion in the liver, and also it inhibits or it impairs gluconeogenesis that occurs in the liver. So alcoholism or anything that causes liver failure, such as paracetamol poisoning or aspirin poisoning, they can also cause hypoglycemia. So anything that interferes with the function of gluconeogenesis of the liver, such as alcohol, which is the most common cause of hypoglycemia, and the second most common is treated diabetes. Other causes of hypoglycemia include insulinoma. How to diagnose a case of insulinoma? If a patient present to you with features of hypoglycemia, the question they mention that his C peptide levels are high, then your diagnosis will be will be insulinoma. So hypoglycemia with high C-peptide level, insulinoma. Hypoglycemia in type 2 diabetic on sulfonylureas, the cause will be sulfonylureas. And in type 1 diabetes, type 1 diabetic present to you with feature of hypoglycemia. What are the features of hypoglycemia? Tachycardia, sweating, confusion, and altered mentation. So if type 1 diabetic present to you with these signs and symptoms, then the cause is most likely overdose of insulin. If type 2 diabetic present to you, then the cause is sulfonylureas. If an alcoholic present to you with these features, then the cause is impaired gluconeogenesis, paracetamol poisoning, aspirin poisoning, anything that causes liver failure can cause a person with these features and with high C-peptide level, then the cause, and they ask you about the cause of the hypoglycemia, then your answer will be insulinoma. So what is the management or how we manage hypoglycemia? The management of hypoglycemia is simple. If the patient is conscious and if the patient can swallow, then we will give 200 ml of fruit juice. But if the patient is unconscious or if the patient cannot swallow, then we can give 10% glucose, 200 ml of 10% glucose in 15 minutes. And after giving this glucose solution, we will repeat. So we have two options if the patient is unconscious. If IV excess is easy, then we'll give 10% glucose or dextrose, 200 ml of 10% glucose. And if the IV excess is difficult, then we'll give glucagon 1 milligram IV injection. And glucagon can also be given IV. The disadvantage of glucagon is that glucagon basically increases the glucose level by stimulating the gluconeogenesis in the liver. So if someone is malnourished or in chronic alcoholics, or if someone have alcohol in his blood, then glucagon, giving glucagon is not beneficial, because the mechanism of action of glucagon is that it increases the blood sugar level by two methods. One is that it converts the stored glycogen in the liver to glucose, and it also stimulates gluconeogenesis. So in malnourished patient, there will be no stored glycogen in the liver, and also in alcoholic, due to impaired gluconeogenesis and due to no stored glycogen, giving a glucagon in such patient would not be beneficial. So the only option for such kind of patient is 10% glucose or dextrose in 15 minutes.
Can you repeat that, please?
10% glucose solution can be given, 20% glucose solution can also be given. But in Plab 1 exam, both of them, 10% glucose or 20% glucose, might not be present together. So we just need to remember that any of these solution can be given, 10% or 20%, doesn't matter. And about the glucagon can be given in intramuscular injection form. So if it's difficult to have an IV access, then we can use glucagon injection. Glucagon causes, or glucagon causes glucose synthesis through stored glycogen in the liver to glucose. So if there is no stored glycogen in liver, then there is no use of giving a glucagon injection. What are the conditions in which there is no stored glycogen in the liver? Two important conditions: in the malnourished people and in alcoholics. So is this point clear to everyone?
Yes, clear.
Some causes of hypoglycemia. Alcohol is the most common cause. Then sulfonylureas and insulin in diabetics, paracetamol poisoning, liver failure. Now, alcohol is the commonest cause of hypoglycemia in adults, followed by treated diabetes. Alcoholism with hypoglycemia. A young adult was found outside a local pub with semi-conscious level, profuse sweating, diaphoretic skin, GCS 12 by 15, tachycardia, and hypotension. So the patient was found outside a local pub, a bar, and he is semi-conscious. He is having sweating, tachycardia, and hypotension. Signs and symptoms of hypoglycemia. So, what is Whipple's striate? Whipple's striate is low plasma glucose manifestations of hypoglycemia, and if the blood glucose is corrected, a rapid resolution of the symptoms. This is called Whipple diagnosis will be hypoglycemia. Low plasma glucose, manifestation of hypoglycemia, and rapid resolution of the symptoms after glucose is given. So if such kind of scenario is given in the Plab 1 exam, then the first thing that you need to, the next step, an alcoholic that is found outside a pub with confusion, unable to speak, and impaired GCS, even coma, then the next step would be to check his blood glucose level and then decide after that what you are going to do with this patient. There are two modern hypoglycemia that are associated with alcoholism. One is hypoglycemia and the other one is hypokalemia. Hypokalemia is due to excessive vomiting because potassium is lost in the vomitus. So alcoholic can have hypokalemia as well. Oral glucose gel can be used in semi-conscious patient. So a semi-conscious alcoholic in which in whom IV access is difficult, we can use oral glucose gel or glucose containing gel. Because if the IV access is difficult, semi-conscious, remember that oral solution, either oral juice or glucose containing gel. Glucose containing gel can be used in a semi-conscious patient, but not in unconscious patient. Because in unconscious patient, there is a risk of aspiration. So that's why we need to avoid oral glucose in unconscious patients. Now, the second acute complication of diabetes mellitus is diabetic ketoacidosis. As its name indicates, it's ketoacidosis. Normally, our body get energy from glucose, and the main transporter of glucose is insulin. It's transport the glucose intracellularly, or it pushes the glucose into the cells, and in the cells then it is utilized through Krebs cycle in the production of ATP and to get energy. So normally our body get energy from glucose, and the main mediator of getting this energy from glucose is insulin. So in type 1 diabetics, when there is deficiency of insulin, then the body shifts its metabolism, or then the body gets energy by formation of ketone bodies. Ketone bodies are found by fatty acid oxidation. So when there is no insulin or there is less insulin in the body in type 1 diabetics, the body start to form ketone bodies such as acetone, and increased formation of these ketone bodies lead to, because they are acidic, so it can lead to ketoacidosis. Due to ketoacidosis, the person pH will decrease. So the criteria for the diagnosis of type 1, sorry, diabetic ketoacidosis is a pH of less than 7.3, bicarbonate ions of less than 15, and because there is ketone formation in the blood, so ketone will be excreted in the urine. So remember these three criteria for the diagnosis of diabetic ketoacidosis. Remember that diabetic ketoacidosis is common in 1 diabetes. So, and type 1 diabetes is an autoimmune disease which is present in young patients. So you can say that diabetic ketoacidosis is common in young, in patient with a history of type 1 diabetes, and the criteria for the diagnosis, three criteria. One is acidosis, such as pH of less than 7.3, and bicarbonate of less than 15, and urinary ketones are positive.
Okay, I have a question. It's written like type 1 diabetes always is the cause for diabetic ketoacidosis, but in practice, we get this in type 2 diabetes as well.
Yes, it can occur in type 2 diabetes as well, but in those type 2 diabetes which are insulin dependent, in which there is insulin deficiency. Usually, insulin deficiency is not present in type 2 diabetes mellitus, but in advanced stages of type 2 diabetes mellitus, insulin deficiency can be present. So yes, type 2 diabetics can also develop diabetic ketoacidosis, but it is very less common. So in Plab 1 exam, the less common questions are usually not asked. But still, if a type 2 diabetic present with these features, that his pH is less than 7.3, his bicarb is less than 15, and there are urinary ketones are positive or capillary ketones are positive, then still you will say it's type diabetic ketoacidosis.
Okay, doc. And another thing I want to ask, is there any blood sugar level that above that there would be ketoacidosis?
Normally, the blood sugar level can be mildly raised or massively raised, such as blood sugar level of 250 milligram per deciliter, more than 250 milligram per deciliter. But to make a diagnosis of diabetic ketoacidosis, there is no specific glucose range, because in a type 1 diabetic mellitus, if these three criteria are met, then you will say it's diabetic ketoacidosis, no matter what his glucose levels are.
I understand. Okay, doc. Thank you.
Glucose level are important to make a diagnosis of hyperosmolar coma in type 2 diabetics. That we'll discuss in the coming slides. So there is a specific criteria for hyperosmolar or HONK coma, in which we need to look for glucose level. But in diabetic ketoacidosis or DKA, no matter what the patient glucose levels are, if these three met, you will say it's diabetic ketoacidosis. Is it clear?
Yes.
So what are the symptoms of diabetes? Young patient with weight loss, polydipsia, dehydration. What are the causes of diabetic ketoacidosis? One cause is that poor compliance with insulin, as gastroenteritis, pneumonia, or urinary tract infection or sepsis. They can all lead to diabetic ketoacidosis and surgery. So, infection and surgery and poor compliance with insulin. These are the three important ketoacidosis: lethargy, anorexia, vomiting, abdominal pain, coma, etc. etc. On examination, there will be small respiration, which is a typical feature of metabolic acidosis. Small respiration is basically deep and sighing breathing, and with a fast respiratory rate. So, vomiting, abdominal pain, coma, and small respiration. These will be the sign and symptoms. And the investigation finding will be pH of less than 7.3, bicarb less than 15, and urinary ketones are positive, will be positive. So, what is the treatment of diabetic ketoacidosis? The initial treatment is always IV fluids. If the patient blood pressure or systolic blood pressure is less than 90, then the first liter will be given in 15 to 30 minutes. The first 1 liter of normal saline will be given rapidly in 15 to 30 minutes. And if the patient's systolic blood pressure is more than 90, then the first liter will be given in 1 hour. Normal saline millimole per liter. When the glucose levels are 10 millimole per liter, then we'll switch to dextrose 5% to avoid hypoglycemia. Also, along with fluids, we'll give insulin at a dose of 0.1 units per kg. So, what is the electrolyte abnormality that is associated with diabetic ketoacidosis?
Initially hypokalemia, then hyper.
Initially,
Initially hyper, then hypo, like that.
so why there will be initially hyperkalemia? Why there is hyperkalemia initially in diabetic ketoacidosis?
It's because potassium is pushed out from the, due to the insulin, it is pushed out into the extracellular space.
Due to insulin or due to some other reason? Insulin pushes the, yes, due to insulin deficiency, uh, that's correct. Due to insulin deficiency, potassium will come out of the cell. What is the second reason of hyperkalemia?
Acidosis.
Acidosis,
The
that's right.
bicarbonate
Excellent.
ion. Yeah.
Yes. Because of acidosis, high hydrogen, the hydrogen ion will go inside the cell and potassium will come out of the cell. So initially there will be hyperkalemia. And why hypokalemia in later stages? What is the mechanism of hypokalemia in?
Insulin.
I think when patient is given insulin, it shifts the potassium
Yes,
intracellularly,
one reason
leading
is
to
insulin. And what is the other reason of hypokalemia in DKA? Yes, Dr. Malia.
Osmotic diuresis.
Excellent. Osmotic diuresis is the second mechanism of hypokalemia in diabetic ketoacidosis. So along with fluids, we need to replace potassium ion as well if on investigation hypoglycemia is present, then we need to give potassium ion as well in the treatment of diabetic ketoacidosis. So three things that we need to use in the management of diabetic ketoacidosis. One is IV fluids. If glucose level is more than 10 millimole per liter, then normal saline, and if it's less than 10 millimole or 10 millimole per liter, then we will use 5% dextrose. Insulin will be given because there is insulin deficiency which is causing all the problems. So we'll give insulin at a dose of 0.1 unit per kg, and also will replace potassium ions if hypokalemia is present. So the third acute complication of diabetes is hyperglycemic hyperosmolar non-ketotic coma. Hyperglycemic hyperosmolar non-ketotic coma. So hyperglycemia, a very high blood sugar level in type 2 diabetes will cause hyperosmolarity or increase plasma osmolarity. And due to high glucose level, what will happen? High glucose will be filtered in the kidney tubules, and due to high filtered glucose, there will be osmotic diuresis as well. So glucose will take water or fluid with itself, so which will result in coma. And this coma will be non-ketotic coma, because the cause of this coma is hyperglycemia, which has led to hyperosmolarity, which has led to increased filtration of glucose in the kidney tubules and increased loss of fluids in kidney tubules. So that's why this is called hyperglycemic hyperosmolar non-ketotic coma. You can just describe it from its name. So what is the criteria for the diagnosis of hyperosmolar hyperglycemic? So the criteria is in its name, hyperglycemia. How much hyperglycemia should be present to make a diagnosis of HONK? Glucose level of more than 35 millimole per liter, which was not a criteria for diabetic ketoacidosis. To make a diagnosis of diabetic ketoacidosis, acidosis must be present and urinary ketones must be positive. So if no acidosis and glucose is more than 35 millimole per liter and plasma osmolarity is more than 350 milliosmol per kg, pH is normal, no ketones in the urine,